Hello, everyone. My name is Tessa Janovsky. Thank you so much for attending this podcast section on MyGap MASLD and NASH Community Network. I'm a physician assistant out of Arizona Liver Health in Phoenix, Arizona. Today, I'm going to be discussing PCP screening for MASLD and NASH and identifying patients at risk. And so which patient population should APPs routinely screen for MASLD and NASH in the primary care settings based on current guidelines and risk factors? And so basically any patient who has a history of hepatic steatosis, probably seen on imaging, should be screened for MASLD and NASH, especially also if they have metabolic risk factors. Anybody who has elevation in their liver enzymes should be taken a closer look at. And specifically, as far as guidelines for high-risk patient populations, ASLD guidelines recommend screening for patients who are at higher increased risk for advanced fibrosis. And these populations include patients with, one, medically complicated obesity, which is the obesity with other comorbid risk factors, such as high blood pressure, diabetes, etc., type 2 diabetes patients, third, MASLD patients, so they have fatty liver on imaging or steatosis on imaging. They have metabolic risk factors, but they also have moderate alcohol consumption. And so with the new criteria, the new nomenclature, this would be MASLD patients. So those patients are at increased risk for more advanced fibrosis and should be screened. And lastly, patients with a first-degree relative with MASH cirrhosis, they are at a 12-fold higher risk of advanced fibrosis. And so those patients should also be screened for MASLD and NASH. And also take into consideration how long these patients have had metabolic risk factors. For example, if I see somebody in the clinic who has had diabetes for 20 years, I automatically have a higher suspicion for more advanced fibrosis, or they could have more advanced fibrosis if they've had diabetes for a long period of time. Next, we'll talk about what are the most practical and validated first-line screening tools for APPs to calculate the risk of advanced fibrosis and suspected MASH, and also what are their limitations, so what to watch out for. And so FIB-4 is one of the simplest non-invasive tests available. It incorporates the AST level, the ALT level, and the platelet count. The objective of this primary risk assessment is to identify patients who are not likely to have advanced fibrosis. And so a score of less than or equal to 1.3, you can be confident that they likely do not have advanced fibrosis. And you can repeat that test based on their comorbid conditions. So if they don't have diabetes or more than 2 metabolic risk factors, you can do every 1 to 2 years or every 2 to 3 years. If they do have diabetes and metabolic risk factors, it should be every 1 to 2 years. So the FIB-4 does come with some limitations. Research suggests that it may not perform well at different extremes of age. And so greater than 65, it may not be as reliable. And also patients less than 35. And also relies on accurate lab results because the AST level is in the numerator of this equation. Patients who drink alcohol, and if they have a greater AST level, that could overestimate the FIB-4. And also patients who have maybe a lower baseline platelet count, their FIB-4 might be a little bit higher. So FIB-4 is going to be the main screening tool that I would recommend. There's also something called the NAFLD Fibrosis Score that is available online, MD-Calc. This estimates the amount of scarring based on several tests. So it includes age, BMI, the presence or absence of diabetes, the AST, the ALT, the platelet count, and also the albumin. And so some limitations on that is that it requires more data points. Simply, it just takes a little bit longer to input those, and so time constraint could be a factor. And also, the accuracy of these results may be skewed based on their BMI. So if they have a higher BMI, it could skew it a little bit. Next comes the question, how do we communicate a positive result? So a positive result indicating advanced fibrosis to a patient, and what are the immediate next steps in management or referral? So first and foremost, we need to normalize the screening. Our goal is to kind of think of the liver as part of the overall chronic disease management in patients with metabolic syndrome or with metabolic risk factors, and just make it part of the conversation. Something that you could say to patients is, for example, as part of managing your overall health and metabolic risk factors, such as diabetes and weight, we routinely check for liver health. And so one of the ways that we can do this is by screening for signs of liver scarring, which is called fibrosis. And when you do get a positive result or a result that would indicate they may be at risk for more advanced fibrosis, kind of explain this clearly and calmly and discuss next steps. And so you could say something like, your results suggest that you may be at risk for advanced liver scarring. Now, this doesn't necessarily mean that you have advanced liver scarring, but just means that we need to do a little bit more. We need to take a closer look to see if you really are at risk for advanced fibrosis. And so, for example, I'm going to order an additional serum blood test, such as the ELF, or I'm going to order something called a FibroScan that's going to check and see if you may be at risk for advanced fibrosis. And also, reassure the patient that if this is caught early, it can be reversible. And so emphasizing the importance of managing the comorbid conditions such as diabetes and metabolic syndrome. And so, at the end of the day, there is good news because we can often slow or even reverse the scarring process if we also take care and manage the metabolic risk factors and work on gradual weight loss over time. As far as next steps in the clinic for an APP in the primary care setting or endocrinology setting, then we'll need to confirm fibrosis with an additional non-invasive test. So either the ELF test or the FibroScan. There's also the MRI with elastography that can be sometimes a little bit more difficult to get insurance approval for. And then also obtaining additional labs to rule out any sort of confounding factors that can contribute to any sort of hepatic inflammation. And so as far as referring patients, referring appropriately to gastroenterology or hepatology if their FIB4 is greater than 1.3, if their ELF is greater than 7.7, or if their VCTE or their KPA on the FibroScan is greater than 8. Also, if you have any clinical suspicion for MASH with fibrosis, send them on over to GI or hepatology, or if the labs and imaging indicates more advanced fibrosis, possibly even cirrhosis, then we would definitely want to see those patients. Lastly, we're going to discuss the challenges and strategies for implementing systematic MASLD and NASH screening within a busy PCP or primary care office workflow. So off the bat, the key challenges include time restraints and busy visits. So providers have they have limited time to address multiple comorbidities. Adding the liver on top of that can be daunting. As far as liver disease is often asymptomatic. So it can be a low priority during limited time visits, especially if their liver enzymes are within normal range. Also, a challenge could be a lack of awareness or familiarity with MASLD and NASH, especially with the new terminology of MASLD and NASH. And also, what are the risk scores? So FIB4 and ELF. So there may just be lack of familiarity with these tests. And then also EMR or electronic medical record limitations. So most EMRs don't automatically flag or calculate fibrosis scores. And if you have missing data points for the FIB4, then that also could be an issue. So possible strategies for implementing systematic MASLD and MASH screening could be incorporating routine risk stratification. So screen at-risk populations, patients with obesity, type 2 diabetes, MASLD, for example. We could think about embedding FIB4 calculators into the EMR or having, online tools or smart phrases, things like that. And making sure that AST, ALT levels and platelets are a part of, annual labs. So that can help trigger a calculation of a FIB-4. To also think about developing clinical pathways, standardized protocols. So if a FIB-4 is greater than 1.3, there can be a referral sent to gastroenterology or hepatology, and building order sets for liver scarring. So, for example, having an order set under the umbrella of diabetes to order a FIB-4, and then from there, triggering protocols to then, if it's greater than 1.3, to send that referral. There are many ways that we can incorporate MASLD and MASH screening in our patient visits, whether it be incorporating it and screening of your diabetic patients on an annual basis, embedding it in the EMR. So at the end of the day, really getting creative on how we can screen more patients in order to locate these patients who unfortunately are at risk for more advanced fibrosis and maybe going unrecognized. Thank you for listening to this podcast episode on my GAP MASLD and MASH community network. I'm always here to support APPs in MASLD and MASH management. Thanks so much.